Hello, thank you again for joining our third educational medical webinar provided by Handi-Craft Company Medical Division, the makers of the Dr. Brown's products. Today I am honored to present Lynn Wolf and Robin Glass, both practice occupational therapists at Seattle Children's Hospital in Seattle, Washington, and both are clinical assistant professors at the University of Washington. Lynn and Robin's clinical specialty is the treatment of infants with a strong focus on feeding issues. They are NDT trained and board certified lactation consultants with extensive national and international experience speaking about infant feeding. Ms. Glass and Ms. Wolf have authored numerous journal articles as well as the book Feeding and Swallowing Disorders in Infancy, Assessment and Management. Both Lynn and Robin will be presenting Feeding the Infant with Cleft Palate, Tools and Techniques. Thank you both, Lynn and Robin.
Thank you, Sandy. This is Robin speaking. Lynn and I are really glad to be able to have this opportunity to share with you our clinical expertise about infants with cleft lip and palate and the clinical management of the feeding difficulties that we have. This is a very interesting group to work with, and as feeding therapists, we have a lot to offer these babies and their family. We're going to begin the presentation by talking about the specific anatomical defects that we see in cleft lip and palate, because this really forms the basis of both the feeding difficulties that we observe in these patients, as well as forms the basis of what we can do to help them have effective feeding. So really, without a firm understanding of the basic anatomy and how that anatomy affects the baby's infant oral feeding function, we need to have this in order to develop appropriate and effective feeding plans for this group. So if we begin by looking at those babies who have clefts of the lip alone, we can have a configuration where it is on one side unilateral or bilateral, and you can see here this is a baby that has a unilateral cleft. It can involve the lip only or extend upward into the nose and affect the nares and the nasal bridge as well. Now, sometimes the cleft of the lip can also extend into the alveolar ridge just behind the lip line, but not actually extend into the palate. And how these factors will affect the feeding function in these babies. If we move on to looking at clefts of the palate alone, very often this involves both the hard palate as well as the soft palate, extending all the way back to the soft palate, as you can see here. They can be very small, or they can be quite large, and they can vary considerably in the shape and the size or the width of the cleft within the oral cavity. So we can have clefts that are U-shaped or V-shaped or more straight-shaped, as this one is here. And in clefts of the palate, we always have free communication between the mouth and the nasal cavity. So there really is a opening, a hole in the oral cavity. Now, depending upon the location of the cleft, whether it is more anterior in the baby's mouth or more posterior in the baby's mouth, because the lips are not involved and the rest of the oral facial features are often quite intact, these can sometimes be missed at birth in the newborn. Now, if we move on to babies that have both cleft lip and palate, again, we can have a unilateral or a bilateral presentation of the clefting of the lip and the palate. Really, the lip and the hard and soft palate are involved, and the nasal bridge is involved as well. So there is really open, free communication in all of the oral structures. Very often we have this large premaxillary segment that often appears rotated and is very prominent on the baby's face. And over the past few years, in terms of pre-surgical management, how we deal with this pre-maxillary segment is an important aspect of the pre-surgical care. And we'll talk about that in just a moment. These clefts in general are extremely large, and there is often minimal to no upper palatal surface within the baby's mouth. You have a free open expanse into the nasal cavity, and this anatomical configuration really influences our later choice of devices that we might use to feed these babies. Lastly, we can have what's called a submucous or a submucosal cleft. And in this type of clefting configuration, we actually have little or no visual evidence of the defect. So what we have is that the defect is in the bony structure or the muscular layer within the above the hard palate, and yet we have visible mucosal tissue below. And what you may see is just a slight indentation or groove, as you see here, that indicates that there is some kind of cleft above. And so what we often see as well is what we call a bifid uvula. So here's the uvula here, and it is in two pieces, called a bifid uvula, and often that is seen in association with a submucosal cleft. Now certainly these bifid uvulas can be observed without a submucosal cleft, but there is very much a high association between these two defects. Now, because there is little visual evidence of the clefting condition, often this is missed at birth. And what we see is that the babies often have difficulty with their feeding function, but why may not be readily apparent. So in terms of surgical management of cleft lips and palate, certainly these are the ultimate treatments for this condition. And the goals of surgery fall into two broad categories. Certainly we want to have an excellent cosmetic result from our surgeries, but we also are paying attention to what is the functional result of our surgery as well. And surgeries in these babies need to be timed with growth of the head, of the skull of the baby, in order to achieve a balance between the functional result and the cosmetic result. The clefts of the lips are often repaired between 3 and 6 months of life. Palatal repairs usually occur later. In our setting, it's between 9 and 12 months of life. And the delayed repair of the palate has to do with allowing adequate growth of the skull and all of the surrounding surfaces to the oral cavity so that you can accommodate this growth as the palate is repaired. Timing can vary from center to center across the country here in the United States, and those centers who are doing much earlier palatal repairs, these babies then often need second or third surgeries later on as the baby grows to accommodate this growth and the changes in the vault of the skull. Also, in the pre-surgical strategies, we have a variety of techniques that are used to both alter the physical placement of the structures so that you get better functional repair later on. As well, we have a variety of strategies that help improve the aesthetics of the repair later on, so that we have a technique called taping, and what that does is it can bring the segments together, mainly stretching the lip and the surrounding skin and fascia of the lips, but also putting some pressure on the premaxillary area as well. When taping first started, we would use just standard infant paper tape, but now we have a variety of specialized taping systems that have been developed specifically for clefting patterns. We also have nasal alveolar devices called NAMs, and these are used to mold the nasal bridge and reposition the premaxillary tissue so that you can get a better repair later. The NAMs are fabricated by our orofacial dentists and really require weekly adjustments and refitting for growth. The presence of a NAM certainly can impact feeding, both in terms of the ease of feeding and the selection of your feeding devices. For babies, they may be removed for feeding, so they are going in and out of the baby's mouth multiple times per day. Now that we've looked at the anatomy, one of the things we also have to go back to looking at is how the basic anatomical defect in cleft lip and palate really affects the basic infant sucking mechanics and what the baby would typically do to generate milk flow, whether it is from the breast or the bottle. And so we know that babies create two types of pressure forces in their feeding process. The first type of pressure force is positive pressure, or a compressive force that the baby's tongue brings to the breast or bottle in order to assist with milk flow. And now babies who have clefts of the lip and or palate, they can usually produce a very rhythmic anterior-posterior movement of their tongue to provide the compressive force. But we do know that compression alone is not very effective for obtaining milk from a breast or a bottle. And so this force alone is not effective in the babies with clefting conditions. And we're going to see these tongue movements in a baby with a cleft in just a minute on a video fluoroscopic swallowing study. The second type of pressure is negative pressure or suction, and this is really the kind of pressure that babies use for very efficient milk transfer, whether it is from the breast or from the bottle. Now, the baby's ability to create this negative pressure or vacuum is really dependent on the baby's ability to have a totally sealed oral cavity, so that in the baby without a clefting condition, this is done by the lips anteriorly around the breast or the bottle and posteriorly between the abutment of the back of the tongue and the soft palate. Now, babies who have a cleft of the lip and or of the palate really do not have this ability to fully orally seal the cavity, and therefore their ability to create suction vacuum is really the major factor. And this is really the feeding problem in cleft lip and palate. It's this inability to create the suction force that affects the baby's ability to transfer milk from any container, whether it's the breast or the bottle. Now, on the bottle, suction is really important for efficient and effective flow, and it's really the efficiency of flow from the bottle that is the issue, because compression can, in fact, create some flow from bottles, but it's not to the fast and easy degree that we would like to see in effective feeding. On the breast, suction vacuum is involved in many aspects of breastfeeding. Firstly, to draw the breast into the mouth and maintain the breast tissue in a teat shape through all aspects of oral feeding. Then the downward movement of the back of the tongue will create the vacuum force that results in milk flow out of the breast, working in concert with the mother's letdown. Compression may be used to stimulate mother's milk ejection reflex, but it really is suction vacuum that is needed for adequate milk transfer. Now, what we're going to see now is the difference between flow rate when we are able to produce suction and when we are not able to produce suction. Let's just see here. There we go. Okay, so here you can see that I am drinking from a straw and I'm using my suction to pull up the liquid. And now we have created a very small cleft in this straw, and hardly anything is coming up here. And we'll show you the small little cleft right here in the straw. We've made a very tiny little slit right here. And so this has severely affected the ability for us to create suction vacuum. And you can see this is a tiny cleft. And so you might hear people say, well, oh, it's just a tiny little cleft in the baby's mouth, but it can really severely affect the baby's ability to generate suction and therefore feed effectively. Now, another factor that we need to consider in cleft lip and palate is the relationship between the clefting condition and the baby's swallowing function. So that firstly, we know that we have communication between the baby's mouth and their nose, and therefore liquids and foods can leak up into this area, and these babies are at significant risk for ear infections because the liquid can then travel down the eustachian tubes, which in the babies are extremely horizontal in their orientation, and therefore it's very easy for liquids to get into this area. Babies, depending upon what size bolus of liquid they are drawing into their mouth, it certainly can affect the amount of leakage they have into the nose. And so this then often affects selection of feeding devices. Also, for these babies, the control of the bolus may not be optimal, and so this lack of oral control can lead to poor timing between swallowing and breathing. And this is magnified when we are having the feeder assist the baby in drinking versus the baby controlling the flow themselves. Also, during swallowing, the liquid may leak up into the clefting area, and after the swallow may drip down back into the pharynx. Now, because the baby has completed the swallow, the baby's airway is now open because the baby is breathing, and there is risk for coughing, choking, or microaspiration if this occurs. Also, as the baby is drinking and the liquid is going up into the nasal area, this may then create stuffiness for the baby, and because the baby's mouth is involved and they are breathing through their nose during feeding, it may affect the timing of their swallow-breathe control as they try to suck, swallow, and breathe with a stuffy nose. Now, typically, babies with isolated clefts of the lip and or palate usually have normal swallowing function. However, the risk of the presence of primary swallowing dysfunction really tends to increase if the clefting condition is concurrent with another genetic syndrome. So we will take a look at a baby with a cleft palate having a video fluoroscopic swallowing study. And you can see, you would expect to see some palatal surface here, and there's nothing there. And this is a squeeze bottle, so the liquid is being deposited at the back of the tongue, but the baby is having a normal swallowing function here as well. So, to summarize the effect of the anatomy on infant feeding, we have a wide variation in the presentation of the clefts of the lip and or palate. And really, for all of the types of the clefts, the main problem underlying the infant feeding difficulty really has to do with the inability to produce a suction force. And therefore, the specifics of the anatomy really relate directly to our choices of treatment and feeding management for these babies. These are going to determine our selection of the devices and how we use the devices, and Lynn's going to talk about this in just a moment. Really, the amount of palatal surface the baby has left over from their cleft will determine what devices we can use, combined with the strength of the baby's tongue movements, and these will all affect whether we select a device that has assist from the feeder or one that the baby is able to independently manage on their own. Secondarily, we have issues related to food in the nasal cavity that leads to increased risk of ear infections. And finally, the timing of bolus management with sucking, swallowing, and breathing is a crucial component in our overall feeding management. So now I'm going to pass things over to Lynn to talk about techniques and tools.
Lynn here now as we change speakers, and the first thing that we're going to do before we talk about specific techniques and tools for feeding the baby with cleft lip and palate, or cleft lip and or palate, is to talk a little bit about what our goals are for our oral feeding. And the first thing that we really need to think about is the fact that we need our oral feeding to be effective and efficient. And what do we mean by that? To be effective, we need the baby to get as much food as possible. So we're trying to optimize their oral intake. And of course, in doing that, we need to know how much they're getting, and we can certainly, check the bottle and find out. But I will say that a lot of times these babies are it is not always clear by looking at the amount of activity the baby is doing exactly how much food they're getting. So many times we have babies that start out with a great eagerness toward feeding. It appears that they're sucking hard, but because of their sucking mechanics and the inefficiencies of their system, they may be feeding for 5 or 10 minutes and only getting a small amount. And we really want to front load the feeding as much as possible, because that is the point where the baby is expecting to deal with larger volumes and is going to actually be able to handle a higher flow and more food a little bit better. So we need to have a good sense of, as the feeding progresses, how much the baby is actually getting. And then in terms of efficiency, we need to make sure that the feeding does not take too long. In other words, efficiency is sort of how much are you getting in a given period of time. And what we don't want to see is the family who comes to our clinic and says, oh, well, they're getting what they need, but every feeding takes us an hour. That's really taking too much of the baby's energy, too much of the family's time for compared with the other things that are necessary for that family and that baby to be spending time doing. So the system has to be effective, as much milk as possible, and efficient, not taking too much time. And also a key is that it has to be comfortable for the baby. If the baby is getting such a high flow rate that they are stressed throughout the feeding, what we're going to find is that over time the baby is going to decide it's just not worth it, that there's too much stress created for this particular situation. Even if they enjoy food and enjoy sucking, they will lose that enjoyment over time. So it has to be comfortable and not stressful for the baby. And of course it has to be safe, and this is mostly focusing on swallowing function and making sure that the baby is, that the food is going to the stomach and that we aren't having any penetrations or microaspirations or aspirations, which are going to then in turn potentially make the baby uncomfortable and or ultimately cause to other medical problems for the baby. And then finally, the system has to nourish the baby adequately. And so while our goal is to maximize oral feeding, if oral feeding is not able to provide enough nourishment for the baby in an efficient way, we may need to look at things like fortification and or tube feeding to make sure that the baby is nourished well, because if the baby is not nourished well, they won't be growing adequately, and growth is what's going to give us improved feeding function over time, and is going to help us actually with intake for the baby. So I want to start first, as we talk more about techniques, with talking about position. And as we talk about position, I want to talk about gravity, and I want to talk about gravity in two ways. First of all, as Robin mentioned, when you have a cleft palate, there is free communication of the food that the baby is taking into the nasal cavity. And not only can this be uncomfortable for the baby, it can set the baby up for more risk for ear infections. And so if we keep the baby in a fairly elevated position with the head higher than the hips, we're going to find that gravity is going to help keep milk out of that nasal pharynx and help the baby then not have the consequences of that. So we want the baby in an elevated position. But then the second thing that we want is we want to think about the bottle being in a more horizontal position. And when the bottle is in a horizontal position, as opposed to a position where it's up in the air with the nipple down below it, it's going to improve flow control for the baby. So in other words, if the milk is, if the bottle has the nipple below it, so that every time the baby gets milk or it's squeezed into the baby's mouth, there is gravity that is helping then to speed up the flow, the baby will have a little bit harder time controlling the flow than if we keep the bottle horizontal. So the positions that we tend to gravitate toward or use are, first of all, the upright cradle position. And you'll notice that this mom is giving a lot of support to the baby's head. This position, you really need to support the baby's head well, especially for a young infant. Older infants, it may be possible that they are developing better head control and need a little bit less head control. But certainly for the young baby, they need a lot of head control. And then the second position that we often use is what we call elevated side lying. And this is a position in this photograph. The baby is on the mom's lap. You can see he happens to be just on a pillow, but he's in an elevated position and he's on his side, which then allows this bottle to becoming at a more horizontal position, and the milk flows a little bit more slowly through the baby's mouth and throat, allowing just a margin of, I'll say it's a millisecond more of time for that baby to organize their swallow and breathe control as they are feeding. And so, of course, you know, while we may say these are typical positions that we consider, for any baby when you're selecting a position, you really need to consider the interplay of their anatomy and their feeding position. So in other words, you may have a baby who is more unilateral in terms of their cleft, and so it may be that one side works better than another. It may be that sometimes we position the nipple, we like to try to do it midline, but sometimes we might position the nipple a little bit more to one side or the other. So you really do have to look at the particular baby and their anatomy. So then in terms of the selection of the tools that we're going to use that are going to help us with the actual milk delivery and ingestion of the food, there are really two strategies that are important to think about. The first of these is that we might consider occluding the cleft. In other words, kind of closing filling the hole, closing the gap, so that we potentially can create the suction that is the basic feeding problem for the baby with the cleft. So that's one strategy. The other is, if we're not able to occlude the cleft so that the baby can develop their own suction, then what we want to do is to provide a device that assists in milk delivery. In other words, that sort of compensates for the fact that the baby is not able to create suction. So we'll look at that first of all in terms of the cleft lip. And it's really important to understand that you do, again, have to look at your anatomy, and whatever strategy that you take has to be based on an understanding of that baby's specific anatomy. With a cleft lip, breastfeeding can work very well, because what we're trying to do is fill that gap in the lip so the baby can create suction. The baby can create suction, can close that oral cavity posteriorly with the soft palate against the tongue, because the palate is not involved. We have to really seal at the anterior portion here. And so, again, breastfeeding can work very well because that tissue will indeed many times fill that gap. Well, of course, that depends how big the cleft is. If the cleft is going all the way up into the nose, it may be much harder to do that. If breastfeeding is not working and or the mother is not making that choice, you can also try using a wide base nipple. And basically what we do with this is we try to insert the nipple so that the base of the nipple is in strong contact with the baby's lips and potentially sealing that gap in the baby's lip. And sometimes in addition to the breastfeeding or the wide base nipple selection, we may use a little piece of tape across the cleft, and that can help pull things together and seal things up a little bit better. Or I've even seen parents just use a finger to put over the cleft in order to seal that gap up. So again, it is very possible to seal the gap on a small cleft lip and be successful with fairly standard breastfeeding and or bottle feeding. But once you get to larger clefts of the lip, you may not be as successful with this because you may not be able to help the baby fully create suction as they feed. Then with the cleft of the palate, how would we close that hole? How would we help the baby be able to potentially create suction? And if you look at the history of cleft lip and palate, one of the techniques that has been tried is what's called an obturator. And this was a molded plastic device that was to fill the gap in the hard palate. The problem being that it could never actually make up for the loss of the soft palate, and therefore you could never really have the seal that you needed at the posterior aspect of the oral cavity where the soft palate needed to connect with the tongue. So these haven't worked completely. Well, they have created a palatal surface, but they have not really allowed you to seal the oral cavity. And then as Robin talked about, the NAMs that are being used more these days, these again tend to give more palatal surface, but they do not occlude, they do not allow the baby to fully occlude the cleft or to seal the oral cavity. So, these strategies are important because of this palatal surface that's created, but don't be confused that they are going to allow the baby to create suction. So then when we think about the next kind of a group of things, now we're getting into more bottles and how we're going to actually bring milk into the baby's mouth. There have been a number of special bottles designed to help effectively create fluid flow or transfer milk for babies who cannot create suction. And there's really two approaches to this. The first type of bottles allow the feeder to assist with the flow by squeezing. And so in other words, the baby compresses, maybe gets a little bit of food, but the feeder is squeezing the bottle or actually compressing externally to provide flow to the baby. And that flow rate is going to be determined by that squeezing pattern as well as the nipple flow rate. And we'll talk about that as we look at some of these products. The second type is nipples that have a one-way valve. And when you have a one-way valve and the nipple is full, as the baby compresses, all of the milk goes into the baby's mouth. None of it is squeezed back into the bottle. And so these valves allow the baby to use compression in a more effective way. Flow now is created by the baby's compression, but the flow rate is determined not just by the strength of that compression, but also by the flow rate of the nipple. These devices tend to work best with babies that have larger palatal surfaces because as they lift their tongue to compress, they have something to compress the nipple between. And all of these devices, it's important that parents receive hands-on instruction. Some of them have complicated parts, then setup can be a little bit tricky, but it's also very important for the parent to learn how to use these tools to match the flow rate to the baby's sucking and swallowing and breathing pattern, because again, it's crucial that the baby have a comfortable level of flow so that it is not only efficient, but that it is not stressful for the baby. The first one that we want to look at here is the Mead Johnson Cleft Lip and Palate Feeder. And again, this is, we call it a squeeze bottle because milk is delivered to the baby. It's a soft plastic bottle. The feeder actually squeezes the bottle, and milk flow is delivered. It comes with a nipple that has a cross cut in it. This tends to be challenging because the baby has to squeeze the nipple in a way that opens up that hole. Oops, didn't work very well. It has to the baby has to squeeze the nipple in a way that opens up the hole, and if the feeder is giving a small squeeze at that point, a little bit of milk comes out. But if the feeder has given a larger squeeze, then a lot of milk might come out. And so there's a variability of flow that occurs with these nipples. And so we tend to put a nipple on this bottle that has a specific hole size in it rather than a cross cut, so that we know that each squeeze that we give delivers a bolus of a certain size that helps the feeder to be able to develop a better feeding pattern over time. And so one of the benefits here, though, is that you can choose a nipple with a hole size that you feel is appropriate for that baby in terms of the flow rate. And then as we're helping parents learn how to squeeze these bottles, it's very important that they learn how to be in sync with what the baby's doing. And it is really sort of a dance between the feeder and the baby as they communicate back and forth about what is working. And you do need to use a pattern of squeezing and waiting and squeezing and waiting. This is not the kind of thing where you just give a steady flow of squeezing and then the baby takes milk throughout that, because the baby does need to stop the flow in order to swallow and breathe, and also to have breathing pauses. The next bottle that we want to talk about is the Haberman Feeder. And this was this is the first bottle that we'll talk about that actually has a valve in it. And the valve is right down here. It's a one-way valve. It lets milk go from the reservoir down here into the nipple. You do want to have the nipple filled with milk. That works the best for getting milk delivery. At least a good amount of fill in the nipple. If the nipple is empty, it doesn't work quite as well. And then the baby is going to compress this part, and presumably the milk is going to go into the baby's mouth. Now, this nipple has a slit in it, which allows it to have variable flow depending on how the nipple is oriented in the baby's mouth. So if the baby is on the highest flow, as the baby gives a small amount of compression to the nipple hole will open, or the nipple slit will open quite widely, and a fair amount of milk can be delivered. This is also a nipple, however, that allows you to assist with flow, because it's so large, the feeder can actually do some squeezing down here. So this is a little bit of a hybrid with a valve and a squeezing sort of feature. And it does allow you to have a fair amount of variety in terms of how you can help the baby, but it then takes a little bit more finesse on the parent's part to appreciate what the baby needs, how much squeezing they need and how much squeezing they don't need. But again, the feeder can help with the flow. It does again work best when there is the most contact with the palate. So a baby that has more of a palatal surface, this bottle will work better on. And indeed, there is a study that shows that this bottle is more effective when a baby has an obturator surface in place than when a baby does not have an obturator surface in place. And then the next bottle I want to talk about is the Pigeon nipple. It's the Pigeon bottle, Pigeon nipple. The nipple is the important part here. And again, you can see here the valve. You can't really see the one-way portion of it, but again, the milk is here and the valve lets it flow into the nipple. It's a smaller nipple. It's a nipple that's fully in the baby's mouth, so that you cannot squeeze this nipple. The baby is going to fully be in charge of the flow. And that's really, you know, the difference between the types of bottles where you can squeeze or assist and the bottles where you can't. Any bottle with a squeeze, the feeder can assist. Any bottle that does not have that feature, the baby is fully in control of their milk flow. And that means that milk flow is going to be timed appropriately to their sucking and swallowing pattern, unlike the squeeze bottles where you may get flow at times that the baby is not expecting it. So with the Pigeon nipple and bottle here, they have recently gone to 2 different sizes. You can see this one is a little bit wider than this one. You can see here they're about the same length. This one is meant to be for a little bit older baby. This is meant to be for a little bit younger baby. This one has a higher flow. This one has a lower flow. The flow for both of them is created by a cross cut. So as the baby compresses it, there's a little triangular cut that opens up. It tends to have a fairly large hole when it opens up, and then milk is delivered to the baby. They have a softer side. One side is a little softer, one side is a little harder. The softer side is meant for the tongue to lift onto that side. But again, these nipples are going to work best when there's a good palatal surface that the baby is squeezing against as they lift their tongue. I did want to point out that because of the cross-cut system here, the flow can be quite substantial from these. Older babies tend to do well with this kind of a nipple. Younger babies may not, and even the slower flow one for the smaller babies can sometimes be too high for a newborn baby. So you need to be figuring out, again, there's that question of flow. What is the right flow for the baby that you are working with? And then the next is the Dr. Brown's bottle with the cleft palate valve. And this is the standard Dr. Brown's bottle, the standard Dr. Brown's nipples. And the addition is this particular valve. And this is a one-way valve again, so milk is flowing from the bottle into the nipple, and then as the baby compresses the nipple, all of the compression force is pushing milk out this way. None of it is going back into the bottle. Again, works best when the nipple is filled. Now, the feeder does not assist with flow. The baby is completely in control of this. The thing that is nice about this is that you do have multiple, you can choose from the standard Dr. Brown's nipples, and so you have multiple flow rates that you can choose from for any particular baby. And this lets you have a pretty fine control over the flow rate for any baby. You can increase that size of the nipple hole if you feel that they can handle the flow and you're trying to help them be more effective, or you can use a smaller hole size if that is the flow rate that helps the baby with their suck, swallow, breathe. It is an open hole, so that it works a little bit differently as the baby compresses the nipple than the tri-cut holes of the Pigeon bottles. So we've talked a little bit about bottles and feeding strategies using bottles, but one of the other topics that comes up often for babies with clefts is what about breastfeeding? And can we have these babies successfully breastfeeding? And the prognosis for full breastfeeding is really dependent on the type and size of the cleft. As we mentioned, cleft lips, we may want to really start with looking at breastfeeding and see if we can use, if that can work well, and perhaps even better than a bottle feeding, because that breast tissue is going to be soft and fill that gap so that the baby can create adequate suction. But with the cleft palate, whether they have a cleft lip or not, it is very rare for the baby to be fully nourished at the breast. That lack of suction really limits both the latch and the milk transfer. And so these babies are not, it's just very, it's very rare actually for a baby to be fully nourished at the breast, and if they are, it tends to occur as they get older, and it depends a lot on both the mom's milk supply and her own anatomy. Some moms do have nipples that the baby can be easily inserted into the baby's mouth. The baby doesn't have to draw them in as much during latch, and if they have a large milk supply with an easy letdown, the baby may be able to actually get enough milk that they could be fully breastfed. But what we tend to talk about more is breastfeeding options in terms of experience at the breast, time at the breast, and partial breastfeeding. And so we do have babies who love to come to the breast. They compress their mom's nipples, they give stimulation, the mom has a letdown, and they spend time there. They get a little bit of nourishment, but they still need supplemental feedings through the bottle. Moms at the breast can also hand express as the baby is there, and this is one of the things that some moms get really good at, and in certain situations this can help babies get more volume of milk. And then there's the concept of assisted flow at the breast, and we've certainly talked about assisted flow with bottles, but how might we do that at the breast? One method is what we would call the tube and syringe over here, and here you just put the little tube into the baby's mouth, and as the baby is sucking at the breast, you are slowly pressing the plunger so that the baby is getting some flow of milk at the breast. A similar device is what we call the Hazel-Baker finger feeder, and rather than pushing a plunger, this is a soft sort of a squeezing type of container. This is tube is in the baby's mouth, and then the mom squeezes this either with her hand, some put it under their sort of in their armpit and do a little squeeze with their arm, and there are other ways to do this. And then finally, there is a device called a Lactaid, and the Lactaid works sort of similarly to the Hazel-Baker in that with compression on the soft bag, you can deliver milk flow through this small tube. And these things are a lot of work, but there are moms that feel that this is, you know, very important to them, and we have had moms that have been quite successful with these. But it takes a special mom and a mom and a baby where this tends to work for the baby. Again, though, many of the babies, even that use all of these devices, do also feed with other bottles and other feeding devices. So it's rare for babies, again, to be only fed at the breast. And we might also wonder about assisted milk through what we call a supplemental nursing system. These are a more standard device that's used with breastfeeding, and I just would say that these do require suction, and so they usually are less effective than the types of devices that are shown here. And we also know that obturators for the cleft are not usually effective with breastfeeding, and we do have studies that have shown us that moms with babies with and without obturators, the obturators do not help the mothers be more effective with breastfeeding. So, things to think about. On the other hand, breast milk is very important, and so despite the fact that, you know, the chances of exclusive breastfeeding are quite low for many of the babies with clefts, breast milk is definitely what we want to support for these babies, and it's obviously usually the best food for infants in general, but particularly for the babies with the cleft palate, since we know that they are at increased risk of ear infection. And there are really some very nice studies that do show the decreased incidence of ear infections in the babies with clefts that do receive breast milk. So that means that our moms are going to need to pump to build and then maintain their milk supplies. And this is one of the key things that we need to help the moms with immediately after birth and throughout the baby's infancy. These moms need to start pumping. Even if they're trying some breastfeeding, we need to appreciate that it's probably not very effective, especially in the early weeks of the baby's life. And so we need to help parents learn pumping techniques and in some ways sort of make peace with the idea of pumping, because it is a lot of work, and it's one more thing that is added to an already stressed mother's life at that point. And then, of course, we need to support them throughout the baby's infancy as they potentially have challenges with maintaining their milk supply. So just now to finish up and summarize, when we talk about successfully feeding the baby with cleft lip and or palate, the number one rule, of course, is the baby has to have adequate nutrition for growth. And we certainly hope that we'd love for all of that to come from oral feeding, but in any case, we hope that a large portion of that will come from oral feeding. But whatever oral feeding system that we determine needs to be an efficient system. It needs to balance the time that's spent in feeding with time for other activities. So the mother has to have time for pumping, the baby needs time for adequate rest, and we need to make sure that the baby is not expending too much energy or calories in the feeding activities. Again, the feeding system needs to be safe. We don't want to be creating respiratory illness and more problems for the baby in terms of their medical condition. And it's important to realize that there's really not just one answer. There is not just one bottle or one set of tools that is going to be the only one that you need in your clinic to help babies with cleft lip and palate. You need to have a variety of things available because you need to match those tools to the baby's specific anatomy and feeding characteristics. And I might also mention that the system that works for the newborn may not be the system that is the best system as that baby gets to be 2 and 3 and 4 months old. So you may need to keep going back and re-looking at what's the best system for this baby. So with that ending, we'll just open it to questions.
I think we are out of time for questions, so I just want to let everyone know that we do have several questions here. I will send these questions to Lynn and Robin, get their answers, and then we will email them to everyone. Thank you again, Lynn and Robin. Your presentation was very insightful and informative. We truly appreciate your time and expertise in the field of infant feeding. Thank you all for joining us. Our next presentation will be on December 11th at 12 noon Eastern Standard Time, presented by Sue Ludwig, President and founder of NANT, who will present oral feeding and the NICU parent, 5 practical ways to empower and educate.